So good afternoon, everyone. We're here today with a very distinguished professor, Professor Rajendra Reddy, who doesn't really need any introduction. He's a Founders Professor of Medicine at University of Pennsylvania in Philadelphia, US. And we're here to discuss a very important and hot topic of discussion in hepatology circles these days, which is recompensation of liver disease.
Good.
So Professor Reddy, this is a new definition that came up with Baveno 7 a couple of years ago. What is the context of the development of this definition?
Well, I guess we have known about recompensation for quite some time. This is not a new phenomenon. If we to go back into diseases such as alcohol-associated liver disease, we know patients get well, and it's not unidirectional where they just progress in their liver disease and they die or get a transplant. They can get better. So more recently, there's been a more stringent criteria of recompensation defined by the Baveno consensus group, where they said that patients who had etiologic cure or control, cure being hepatitis C, control being hepatitis B, or alcohol cessation, and they had complications of decompensated cirrhosis such as ascites or encephalopathy, if they were to resolve and particularly stay off of diuretics for ascites or anti-encephalopathy treatment for encephalopathy for a certain period of time, they would be categorized as having had recompensated liver disease. So preliminary studies, such as in hepatitis C, such as yours, suggest that maybe a fifth to a quarter of patients recompensate with hepatitis C in the background when they are cured. It may be the similar number for alcohol-associated liver disease, perhaps a little higher for hepatitis B. But this is something that needs to be studied further. And what are the implications? The implications are that if they have recompensated liver disease, they can hopefully avoid transplant or the liver transplant over the long run and feel well. There's a certain amount or element of feeling well as when they recompensate. So it's an important concept. It's a reality, and it's something that we really need to present to our patients and tell them that they have hope. Okay, that it's not all bad. So something that's good.
So that's a really great point, and I can draw the audience's attention to your previous study where you use a surrogate of attainment of MEL less than 10 or the attainment of Child-Pugh A. So vis-a-vis the attainment of a stable liver disease versus the more stringent definition of recompensation, which requires the patients to be off prophylactic medications for a period of 1 year without a recurrence of the decompensation. So a recompensated patient would be a subset of a patient who's otherwise medically controlled and has attained CTP-A, despite maybe having a previous decompensated disease, child C, maybe waitlisted for transplant and then delisted because of clinical improvement. One of the pitfalls I think from this would have been from the early transplant studies where some of these patients got relisted because patients with alcohol use may have a relapse of alcohol intake, and patients who have maybe MET-ALD or MASLD, they never really have a correct cure or an etiology suppression that is absolute. So what is your take on the re-decompensation? How should these patients be completely taken off transplant listing? Are they still at risk of hepatocellular carcinoma, for instance?
So, first of all, if they recompensate and they have consistently improved liver function, they should be delisted. And the probability of recompensation to a point of delisting happens in the relatively low MEL
categories,
and also maybe child class B. It's less likely that a child class C or someone with a MEL over 20 at the time of listing is going to recompensate to a point where they can be delisted. Nevertheless, it does happen. That's one thing. Two, the time to recompensate is quite long. It does not happen overnight or first 3 months. As you showed, it's on an average 14 months. And so we recently analyzed data from the UNOS database and noted that the hepatitis C patients tend to get delisted after 3 years of being listed. So that's the amount of time it takes for them to show improvement. In alcohol-associated liver disease, they can potentially get delisted within about a year. So delisting does happen, but their point is also very important that although they have recompensated, they're always at risk for something, particularly liver cancer. So they need to really be monitored. And what we noticed is that the ones who are delisted, who get relisted, often are relisted for liver cancer. So they are not out of the woods, so to speak. They'll have to be on a radar screen even after recompensation. A patient cannot say, oh, I'm done well now, I can, stop seeing a physician.
So there are nuances to the definition as well. First of all, the etiology, some things are absolute cures. So alcohol cessation entirely, hepatitis C offers entirely a cure. But with HPV, we have chronic virological suppression. With patients who have multi-factor or cardiometabolic risk with ALD, again, it would not be a complete etiological cure. So do you think there's, I understand that patients who are child B would have a higher probability of maybe attaining child A. But then there are also patients who have, say, just variceal bleeding. Maybe they could recompensate earlier than patients who have ascites, because we continue with beta blockers. Those are, they're not included as the prophylactics being taken off. So diuretics, rifaximin, lactulose, etc. have to be off. But things like beta blockers, we do continue.
Yes,
HCC surveillance as well.
We do continue beta blockers. So that's one, it's an important point. That is one drug that has been shown consistently to decrease liver-related events over the long term. So I certainly would want to continue beta blockers. So diuretics, if they are really well controlled, you can try off of diuretics. Similarly, encephalopathy medication you can try, but beta blocker should be continued.
There are issues with this definition as well. Many a times we give diuretics because the patients have pedal edema occasionally, and we give lactulose because they have constipation. So this definition of requiring these drugs to be off entirely may require some moderation in the future.
You are absolutely right. So that's rather stringent criteria. That is something that applies to perhaps a certain percentage of people who actually recompensate. What is important is what is clinically meaningful. How's the patient feeling? Someone who has a lot of ascites, sarcopenia, hypoalbuminemia, and recompensates and feels well. What difference does it make if they're taking a small dose of diuretic, or taking lactulose? So I think the definition has to be relooked at.
Even the time to recompensate. Because our patients attain CTPA rather quickly. I would say they would attain it within 6 months of the etiological suppression or cure, as the case may be. Whereas to recompensate, we would at least require that 12-month washout period. Maybe earlier in patients with variceal bleed, but certainly for other decompensation events.
So that's an important point, because when I see a patient with alcohol-associated liver disease, alcohol-associated hepatitis, and decompensation, the trajectory of recompensation is such that you see fair amount of improvement if they're going to improve in the first 6 months, but then it may take up to 12 months. But then thereafter it plateaus. So alcohol-associated liver disease tends to recompensate faster than, say, hepatitis C, which might take a couple of years.
So there's an etiology-specific moderation of the definition as well. Couple of points in addition. So one thing would be that these patients may get delisted from transplant listing. What about TIPS? Do you think that could be considered as a pan-etiology modifying agent that could reverse portal hypertension?
This is a question that comes up often. TIPS currently is indicated for patients who have variceal hemorrhage or have refractory ascites and then hydrothorax. So by definition, when they decompensate, they either had ascites or had variceal hemorrhage. So there's an indication for TIPS. So as such, you could consider placing a TIPS. And it's been shown to improve nutritional status and then resolve
Control the
situ-
situs, exactly.
Yeah, right, yeah. What I don't want people to do is place tips when they do not have those complications with the hope that they would recompensate.
So it's not a surrogate for an etiological cure.
Exactly. Yep. Etiological cure, or it is a intervention for a decompensating event.
Correct.
Right. So, and which can lead to recompensation. So, of course, that's the whole idea behind the tips.
We're having more and more tips being done, I would say,
Yeah.
in clinical practice, whether it's for bleeding or, now there are those controlled expansion stents, etc., which, don't have as high a risk of hepatic encephalopathy in follow-up.
Right.
So maybe that is something that in the long term we may get
Well, maybe we'll be
data.
doing more readily tips as
Correct.
opposed to waiting till very refractory.
Absolute
state.
indications, right. From an Indian perspective, I can say we're a resource-constrained country, and the access to transplantation is not as clear as in the West. Secondly, the kind of transplants that are done in India, frequently living donor, there are ethical concerns there.
Yeah.
So the concept of recompensation is very exciting from an public health point of view, because it reduces the cost of treatment of advanced liver disease, reduces the risk of HCC in the long run. So even if patients remain at risk and are on surveillance, they are definitely at a lower risk of HCC. In the context of, in the West, when we are considering transplant as a primary treatment available, do you think that recompensation would also attain a endpoint of treatment in patients with cirrhosis? Is it there in the treatment guidelines?
Yeah. So, I want to tell you something about it. So, the ones who recompensate do not necessarily, based on the data that we have, behave as patients who never decompensated.
Correct.
So, they behave better than the ones who continue to in a decompensate state, but not necessarily as well as in. So, having said that, while it's a desirable and good, endpoint, it may not be the ultimate. So they still have to be on the radar screen, and transplant may become necessary. It's possible that someone with alcohol-associated liver disease who recompensates and never drinks alcohol again may do better over the long term. So something that you need to keep in mind. I wish we had greater access to transplant for all our patients, but hopefully there will be less of need of transplant in those who recompensated.
So definitely it's well defined for viral hepatitis, but maybe also for alcohol-related liver disease, but there are rare diseases. For example, autoimmune hepatitis or primary biliary cholangitis. There would be no definite cure, even if histology shows that there is reduction of fibrosis or, histological remission. There's another concern with the new nomenclature of MASLD, MET-ALD, and the ALD spectrum, and the increasing use of PET testing in practice. Patients who are once considered as MET-ALD after alcohol cessation may remain with cardiometabolic risk, albeit with control, but they might then transition to a MASLD group. Whereas a patient who was ALD with cardiometabolic risk with alcohol cessation would now become MASLD alone and not ALD. What is your take on this nomenclature and the change in it, and the patient may flit between one end of the spectrum to the other?
Right. So this nomenclature, I guess, has served some purpose, but the points you make about it being
a fluid
not
spectrum.
a pretty silo condition or conditions, it's people can go back and forth, so flip. So regardless, I think the goal should be of a holistic approach to these patients. Obviously, no alcohol, whether they have MASLD or MET-ALD. Control the cardiometabolic risk factors well, requiring diabetes control, hypertension control, and dyslipidemia management. Now, granted that the safety of statins is not in a comfort zone when it comes to child class B and C, But yet, if they have an indication for dyslipidemia, they should use it
They should
because
use it.
the relative benefits are greater than the risks. So that's something that I always preach. And of course, child class A, even if they had cirrhosis, they should use a statin if there's a medical indication.
Correct.
For statin. But at this stage, we cannot proactively recommend a statin for decreasing cirrhosis outcomes.
Because statins have pleiotropic effects. The study by Braldus showed a survival benefit of adding simvastatin to patients with disease because it corrects portal hypertension.
Yeah. So
the second scenario where there's a lot of dyslipidemia which is not talked about is alcohol-related dyslipidemia because they have hypertriglyceridemia with active alcohol intake. In fact, that's a marker. And just stopping alcohol might reverse it, but then there are some patients who would require pharmacotherapeutics with AH. So do you use any anti-lipidemic agent with the triglyceride of 500, patient has just stopped alcohol or is having intermittent intake?
Definitely.
Fenofibrate or
use fenofibrate for hypertriglyceridemia, and then of course if they have high LDL, high cholesterol, we can use a statin.
Statin as well, because cardiometabolic risk has cardiac events as well. So sometimes the deaths in these patients would actually be due to non-liver disease and maybe cardiac death related. So I think we have covered all our talking points. If there's something that you have as a take-home message or a pitfall of the idea of recompensation which young hepatologists would like to listen to.
The message is, one, this phenomenon being brought to attention is good for the practicing physician and particularly the patients.
Yes.
So you can tell the patients, hey, listen, there is hope for you. And there's a tendency to just have them go for transplant if they have decompensated liver disease. That's one thing. Two, there's a tremendous need, to address several clinical outcomes or questions in this population still. Only about 1/4, 1/5 recompensate. What is it that predicts recompensation, and what are the factors that say that he's not likely to recompensate? And if they're not likely to recompensate, what interventions can be introduced to facilitate recompensation? Because that's a huge unmet need still. Two, we need to identify good predictors of recompensation, particularly in alcohol-associated hepatitis, because there are no predictors, and so and patients are readily sent to transplant, but I feel that we do more transplants than are needed in that population, so that's another thing. We need to look at long-term outcomes in those who have recompensated. Biomarker development is important for either predictors or non-predictors of recompensation. So these are all important areas of research that hopefully someone will take on. Again, we do research for our patients, right? So to try and help them understand the disease as to what the outcomes might be, etc. So it's important that we continue, investigating various areas or various endpoints, various tools in our patients with advanced liver disease.
So I think recompensation is a very exciting field to be working on. I mean, because it's opened up an area of hope, as you say, and an area of research, because that could be a clinical endpoint in some cases as well.
Right.
So it is exciting, and I hope we have more people interested who would want to work on the subject. So we welcome topics and more discussion in the field.
Well, more to come as we move on. All right.
All right. Thank you, Professor Reddy. We had a wonderful time chatting with you, and thank you, Team BLS.
Thank you.